My name's Rupert Dunbar-Rees. I run an organisation called Outcomes-Based Healthcare. We are a specialist health data analytics organisation focusing on outcomes measurement both nationally and internationally. And today I'll be talking about work which is focused on England, but which has an international dimension. So February 2020 saw the launch of the All-Party Parliamentary Group for Longevity. Their report was The Health of the Nation, and there was one significant headline in that report which revealed that we may be spending an ever-increasing proportion of an ever-increasing lifespan in poor health, and that proportion of one's life which is spent in poor health may be actually greater than we had previously thought. And so this is based on work undertaken in the UK locally over the last few years by ourselves and with NHS collaborator organisations, translated nationally into centrally held data sets as part of a national pilot to measure HealthSpan using objectively recorded health and care data. This work has been done in partnership with NHS England, Public Health England, and Arden and GEM Commissioning Support Unit. And I think one of the key points underlining that work is that the effect of this poorer health span than we perhaps thought is that it's not shared equally among all people in society. So I'm going to share some details underpinning that data work and how that relates to the longevity research work underway nationally and internationally more broadly. So the starting place for looking at this kind of data is to measure flows between population, what we call population segments. And I guess the most important of those movements is measuring flows out of the healthy or generally well population segment into any other segment. And that's what we call health span or healthy lifespan. And it measures principally the first movement out of the healthy or well population segment. Of course, that's not the only movement in health state which is important. Similarly, as people progress from having a stable long-term condition to developing organ failure, for example, if someone progresses from having stable kidney disease to end-stage kidney disease, that's a significant progression and usually associated with significantly worse health outcomes and also poorer health and well-being generally. And so it's important to be able to measure these flows using person-centered data, which spans multiple different care settings, which I'll come back to in more detail in a moment. So to measure these flows on a very granular basis and measure them dynamically and longitudinally over a period of time, we really need a robust population segmentation model. And so the model that we use for that is something called the Bridges to Health segmentation model. And this was originally developed as a concept by Joanne Lin and colleagues in the US in 2007. And we spent the last few years building the data model around this, in particular, initially based on UK NHS data sets and health and care data sets more broadly in the NHS and social care, and with the ultimate intention of being able to create something that's internationally translatable. And as you see, broadly, people flow from healthy or generally well into having one or more long-term conditions, plus or minus serious disability. And then ultimately, most of us will flow through the end phases of life of incurable cancer, organ failure, frailty, dementia, and perhaps even all three. We do know, however, that many people actually stay on the left-hand side of this flow diagram, if you like, and actually live well into their 90s or sometimes beyond, and still remain essentially very healthy. And obviously, the greater proportion of time people can spend on the left-hand side of the segmentation model here, the better, not only for them, but also for society more broadly, and overall lifetime cost of care, for example, because all the way through that journey, people will be accessing and needing care when they become acutely unwell. And the kinds of care that they'll need when they're acutely unwell are very markedly different if someone remains fundamentally well than if they have incurable cancer or organ failure, obviously. But we're able to, now that we have a person-centred data view, particularly using some of the strengths of NHS health and care data systems, we are able to actually measure and monitor some of these movements and get a real handle on how we can improve the journey for people through life, through this life course view, and trying to hold people in the healthy well state or help hold themselves in the healthy well state for as long as is possible. So obviously there is a lot of detail that underpins the segmentation model. The largest population segment, barring the healthy well segment, is the long-term conditions segment. And as you'll see from this slide, there are actually a very long list of long-term conditions which are available to be included within that segment. Everything from sort of common things where there's a lot of consensus, so diabetes, coronary heart disease, asthma, depression, serious mental illness, and so on, usually are at the top of the list of what people would consider to be a chronic or a long-term condition. But when you get to the sort of, when you get further and further down the list, maybe beyond sort of the first 30 or 40 conditions, you enter into some conditions where there's some debate, such as, is back pain a long-term condition? What about various skin conditions and so on? And there really is not much consensus nationally or internationally as to what is the sort of ideal list of long-term conditions that should be included in any segmentation model. So we've spent a long time, a few years now, looking at across the evidence base nationally and internationally around where there appears to be consensus on what is a long-term condition. We've included those in a default configuration here for the purposes of our work with NHS England. Similarly, disability, there are various different ways of defining disability, which are set out here. Similarly with incurable cancer, organ failure, and frailty and dementia, I think that the main thing here is around being clear about what your configuration is that you're using and why you're using those cut points. There is no right answer here in terms of defining population segments. We try in our work, we try and evidence-base as many of those decisions and definitions as possible, so that people, when they understand, if I show a figure like on the first slide of HealthSpan, someone's HealthSpan, the population's HealthSpan in mid-50s, people need to understand that what are the conditions that would mean that your HealthSpan was in some way impaired. And so I think it's really important to be clear on definitions, but as I mentioned, there is no right or wrong answer. At the bottom of the segmentation diagram, you can see there are a number of transient stages that people may tend to go through in terms of maternity services and so on. These are episodic segments that women can move in and out of, and they can belong to a number of different segments. They can have an underlying long-term condition, be healthy or well, have disability, and so on. But ultimately, then that runs alongside, if you like, someone's base health status. And similarly with the episodic care that I mentioned earlier. So what does this look like when applied nationally? So this is some work underway really over the last year to translate that into centrally held data sets, which typically don't include primary care data, at least not in this country. And so it's not a precise science, but we have been able to calibrate the national work with areas that do have linked data sets, which include primary care, and actually we're pretty close, even with the loss of even with the lack of primary care data, pretty close to some of what we might expect to see if we had primary care data to process nationally. And we benchmarked and calibrated the segments against existing known benchmarks, such as the Quality and Outcomes Framework, various condition registers, and so on. So for each of the conditions on the previous slide, the prevalence is calibrated against QOF data, NHS England data, various national audit data, and so on. And the idea is that we can measure flows through these population segments as people acquire those conditions and so on, along the life course. And then we can see the sort of demographic profile of people in society. And so this has been applied to data really for anyone registered at a GP practice in England, less opt-outs, less any national opt-outs. And we can see the demographic profiles rising from a sort of fairly young median age of the healthy well cohort in the region of 40, right the way through to sort of frailty and dementia, which is closer to 80 or so, and quite a wide distribution of ages in those with disability, as you might expect. We can also see the various gender splits. And then something I referred to earlier in terms of the role of deprivation on the right-hand side of this slide, whereby the least deprived have a relatively higher degree of healthy or well people in that decile compared with the most deprived, and there's a fairly predictable deprivation gradient to that data. So this is just to give you an idea of the sort of population sizes that you might see, or the demographics that you might see when looking at this on national data. Turning to local areas where a lot of our work is focused on local areas where we do have privacy protecting access to some primary care information, enough to be able to establish core diagnoses on an anonymised basis, barring any opt-outs that have been put in place, as I mentioned earlier. And what the sort of typical sizes that we see in terms of the adult population for those segments is the healthy and well cohort is approximately, usually somewhere in the region, sort of mid-50s% of the population, approximately a third of the population having one or more long-term conditions. And then those those sort of disability and end phases of life, accounting for a relatively small percentage of the population at any one time. This is based on data for a local area in the financial year of 1819, where people are assigned to their highest acuity segment only. And although those population sizes are relatively small on the right-hand side of the slide, oftentimes people in those population segments tend to disproportionately account for acute and community care expenditure and activity. So what that looks like when we see all ages, obviously, because if we include the under 18s in those figures, we will tend to find that a significantly higher proportion of under 18 are healthy or well, at least when measured in clinical terms. That has the effect of increasing the population size in the healthy and well cohort and reducing the relative proportions of the other population segments, as could be anticipated. So moving on to the movements out of the healthy segment and into any other health state. And all of this really goes to underpin what I'm going to come back to in a moment, which is measuring population level health span. So there are a number of conditions which tend to occur more frequently when moving out of that healthy well group into other groups. And interestingly, we typically find this is based on a variety of local information, again, where we can see far more precisely when people moved from one group to another and what conditions they were moving with. So mental health tends to come up quite frequently, and that's probably is probably a feature of two things. And so these are the conditions which people first leave the healthy cohort with. So that means that things which are both high incidence or high prevalence and having a young age of onset will tend to dominate the most common conditions for marking first movement out of the healthy or well segment. And thereafter, as people have additional long-term conditions, they may then progress to sort of 2, 3, 4, 5 long-term conditions. We tend to see some of the more established long-term conditions that occur oftentimes in towards sort of 40, 50, 60 years of age, such as coronary heart disease, COPD, and so on, starting to become more dominant. But certainly when we take a population view, looking at the first condition that people experience, which sort of marks that move from being well, tends to be these sort of depression, arthritis, cancer, asthma, those kind of diabetes, those kinds of conditions. Obviously, that's not a one-way movement, and certainly with linked local data sets, it's possible to measure movement both out of the healthy segment and back into the healthy segment. So if someone has a significant episode of depression, which lasts for maybe 9 months or so, 12 months, and then they recover, then we can measure movements back into the healthy segment, and we can cumulatively measure the sort of cumulative health span, if you like, of the population using existing routinely collected health and care data. Just a note on gateway conditions, on the wording. Obviously, we don't know whether these are truly gateway conditions. That's an open research topic. This may just be a sequencing artifact, that certain things come sooner than other, certain conditions come sooner in someone's life course than other conditions. But it is an interesting research topic to determine whether there is, if by addressing one or more of these gateway conditions proactively, is it possible to slow down the journey from one to many long-term conditions? And I suppose part of that is around understanding what the sort of what the age profile is and the age distribution of each of those long-term conditions. So this slide is showing what age people are first experiencing those conditions, and what the distribution of that is, and fairly predictably, some conditions have quite a broad distribution or first age of onset, and other conditions have a fairly tight distribution. Some are modifiable, some are either preventable entirely, some are able to be delayed by a year or two with appropriate interventions. And really, this is starting to get into really the final part of the talk, which is around measuring HealthSpan. So HealthSpan measures the cumulative effect, the net total, if you like, of either delaying or preventing the onset of these conditions. One of the challenges that has bedeviled this kind of work is that if you delay or prevent one condition, then you go on and the argument goes that you go on and may develop another condition instead. So therefore, there isn't really any benefit the argument goes there isn't really any benefit in prevention, because if you don't get one thing, you'll get another thing anyway. And really, this is, unless you take a whole population, a whole holistic view like this, then it's very hard to address those kinds of concerns. But in essence, by measuring the age of onset of the net total of these, that's in essence what we've been measuring with HealthSpan. And how does that differ from existing ways of measuring healthy lifespan? So there's a summary here on this slide, and also on our website. The links are at the bottom of the slides. So the two most common ways of measuring healthy lifespan, both nationally and internationally at the moment, typically healthy life expectancy and disability-free life expectancy, at least at a whole population level, rather than for a specific intervention, where for a specific intervention we tend to be talking about QALYs and DALYs. But from a whole population basis, trying to understand how many years we're living in good health. HLE and DFLE are the predominant measures at the moment. These are self-reported survey samples for a small percentage of the population who are asked to rate their health subjectively. So they provide a very good measure of how healthy people feel they are. It's very important. It's also internationally standardized, and so very helpful for us to get a feel for how healthy people say they are. That doesn't necessarily always tie up with with the objective view of how healthy people are. So quite often, sometimes people will report fairly good health whilst experiencing what might otherwise be considered objectively quite poor health. And that's really where HealthSpan as a measure comes in, because in essence, those conditions that I identified above in the earlier slide contribute towards, we can understand what the contribution is of those conditions towards someone's overall healthy lifespan. And we can measure those in pretty close to real time, because the data structures exist that allow that data to be analysed in near real time. So there isn't a sort of survey delay. It's possible to measure it for a whole population and track it, and also measure the effect of interventions, either policy interventions or healthcare interventions and so on. So we can measure the effect of how well we are keeping people, helping people themselves stay in that healthy, generally well cohort, and also actually measuring the financial impact of all of that activity. And so what does this look like on a national level? So this was a pilot work that we were undertaking with NHS England, Public Health England, Ireland and GEM CSU to establish, using this objectively recorded data, what the first look, if you like, at measuring population level health span suggests. And we have a figure here of the mid-50s. We're doing further work on this number to refine the number, to see if we can get a little bit more accurate. It's slightly higher than we would normally expect when we view this in local areas. And as you'll see there on the right-hand side, it's suggesting approximately 65 to 70% of someone's overall lifespan is being spent in good health. And it is actually lower than previous estimates. So previous estimates, often based on HLE and DFLE, of how healthy people feel they are, suggest about 75 to 80% of someone's lifespan is spent in subjectively good health. So it's quite a significant difference there, and that may account for some of the increased expenditure in health and care that we've experienced over recent years, certainly prior to the recent COVID pandemic. So how does HealthSpan line up against HLE, the most common, the closest existing metric that I mentioned a moment ago? So we see both the average health span being lower than HLE, and also the distribution, because we're measuring the effect of all of the people in the population, and when they move out of that healthy group into another health state, we are able to see the breakdown, if you like, of those movements. So we can see the most common, the most frequent, and the average movements out of that healthy cohort, split by gender, deprivation, and so on. And similarly to healthy life expectancy, there is a gradient, there is a deprivation gradient. The sort of health span gap, if you like, is quite significant from most to least deprived. When we use the national deciles, it's even greater when we look at local areas, because we're measuring whole population data rather than sample data from a small population. It actually enables us to get down to a much lower level of specificity from one area to the next in terms of healthy lifespan. And we can see a far greater divergence between those areas than would have been the case if we'd looked at sort of local authority level, for example. But we do still see that deprivation gradient in health span, which you see in healthy life expectancy. So what does it mean in terms of pounds and pence and lifetime costs of care? Well, As you can see, this is based on our work in local areas. This is the sort of typical acute healthcare expenditure per segment, where we were able to identify what is the how many people are there today in the healthy well segment, or this year in the healthy and well segment, how much did we spend on their acute care, and so on and so on, and follow that through for each of the segments. And so this is based on real expenditure data. And this can be kept up to date each year, so we can see, or each month, so we can see how well we are, how well our efforts are paying out financially in terms of reduced expenditure or increased expenditure for various of those population groups. So although people who are basically healthy and well sort of in the £300 to £500 a year territory for acute outpatient A&E and admitted patient care. Because of the size of that population segment, as you saw earlier, over half of the population in that group, cumulatively, for one area, I think this is an area based on 300,000 people, approximately getting on for £40 million is still spent on those people, and approximately double that for people with one or more long-term conditions. But it's when we get towards the end phases of life, obviously, that the per capita healthcare expenditure gets very high, disproportionately high in proportion to the population segments concerned, and the sizes of the population segments. So I think the key message here is that the longer we can hold people, or the longer people stay in that healthy and well segment as a proportion of their overall lifetime, the lower the overall lifetime costs of care. I think this is a really important point, and it relates to so-called compression of morbidity, which James Rees described in the 1970s as a sort of theoretical concept. And I think here we can actually start to see compression of morbidity being measured and being played out, and we can start to research, is it really possible to compress morbidity, or for each extra year of healthy lifespan, do we just add on another year of overall lifespan? And I think the suggestions from the data that we're working with at the moment suggest that actually it is possible, it may be possible to compress morbidity into the last few years of life. And actually it is possible to increase health span faster than lifespan. And if we do that, then there is a possibility that increasing lifespan is not necessarily associated with overall increasing lifetime costs of care. And to just illustrate that point, again, this is based on some real historic data from a local area, approximately 300,000 people, where we have a health span in this area of sort of mid-50s years of age, lifespan sort of low 80s in terms of years of age over 3 successive financial years. And we can see that the health span to lifespan ratio there is actually falling in this area slightly towards, in this case, 60% of people's life being spent in good health. That has significant implications in terms of unsustainability of healthcare systems from a financial perspective. And really what we're looking for is health span to increase faster than lifespan. And if we do that, if we can improve that health span to lifespan ratio and compress morbidity, then we can expect that overall lifetime costs of care may actually fall because of the greater number of years being spent at sort of £300 to £500 a year instead of £9,000 a year. And this is a really important point to be clear on. Otherwise, we will be forever trapped in a situation where economists quite rightly say to us, we can't afford increasing longevity. I think the emerging evidence from this work is that we may actually be able to have our cake and eat it through increasing lifespan, increasing healthy lifespan, but lower overall lifetime costs of care. So I think there's a real opportunity here through work of this kind. This has been based on UK data across all care settings, which enables us to take a person-centered view rather than an organization-centered point of view. What's enabled that is a high degree of digitization, a single longitudinal person-level identifier, the NHS number in effect, or the pseudonymized NHS number, which enables us to join the information across different care settings to get a person-centered view of of someone's care, rather than just the bit that people see when they access a particular hospital. I suppose the third thing is that is good whole population coverage, which helps us overcome some of the patient selection bias issues. So if we have a good high degree of digitization, a single patient identifier, but we've only got sort of 30 or 40% of the population within a data set, then it creates obviously challenges around understanding how representative that 30 or 40% is of the total population. And we're very fortunate in the NHS to have most of those key ingredients. And having calibrated HealthSpan, Healthy Lifespan, with this very fine granular data, particularly involving input from primary care, and that's now been translated towards a standardized international coding terms such as ICD-10 and OPCS. Really, for the first time now, having undertaken this work, it is possible to envisage other health and care systems internationally that have a high degree of digitization, reasonable level of population coverage, and a single person identifier to then start to measure daily, monthly, yearly population level health span, and understand the effect of the ability to, whether they can compress morbidity and lower overall lifetime costs of care, improve healthy lifespan. So that's everything I have today. There's plenty more on the website if you're interested, and also in the APPG report, which I mentioned at the beginning of the talk. Thank you.